it's really an honor and a privilege to be presenting to such a wonderful panel, as well as to the August All India Ophthalmic Society gathering. So I'll just be going through a few cases, but let's start with a little bit of an introduction to our topic. You know, the eyes are called the windows to the soul, but I really believe that the retina is really a window to the rest of the body. It's uniquely accessible, and it's the only part of the body where we can actually see the blood vessels, neurological tissue, and the underlying vascular choroid has the largest blood supply per 100 grams of tissue in any organ system of the entire body. So we can always boast to our non-ophthalmic colleagues that we really have something special within the eye. So needless to say, various vascular disorders can manifest within the retina, including diabetes, hypertension, hyperlipidemia, but also systemic vasculitis and infections, including HIV. Neuropsychiatric disorders are really of great interest in today's day and age, and some of these are areas of intense research, especially with regard to their retinal and optic nerve manifestations. Hematological disorders like malignancies, anemia, hemoglobinopathies, and hypercoagulable states can also leave their mark on the retina as well as other parts of the eye. So let's jump in and see this fundus image. This was a 42-year-old gentleman who complained of drop in vision in the left eye since about 15 days. And here you can see the classic picture of dot and blot hemorrhages scattered in all quadrants of the retina, a diagnosis that is not very difficult to make, but it warrants further investigation. And naturally, on further investigation, these were all the comorbid factors. In a 42-year-old gentleman who otherwise had no systemic complaints, we found him to be diabetic, hypertensive, and have hyperhomocystinemia. So this is a fairly run-of-the-mill situation that one encounters in day-to-day practice of truly life-threatening diseases that could manifest first to an ophthalmologist. Moving to something a little more sinister. This was about 6 years ago when a 33-year-old gentleman presented. He was perfectly healthy and came only for refraction. His best corrected visual acuity was 6/6 N6. And our fellow who examined him in the OPD also had the presence of mind, as it is a protocol in the hospital also, to examine the fundus and referred the patient to the retina department, saying that this patient has bilateral central retinal vascular venous occlusion. This was the fundus image at presentation. Now, there are these hemorrhages scattered in all quadrants in both eyes, but what was important to note, if we magnify and zoom in, are those hemorrhages are not the run-of-the-mill dot and blot hemorrhages, but these are nothing but Roth spots. They have a pale white center within the hemorrhage. If we recall our teaching, causes of Roth spots could be infective endocarditis, systemic sepsis, leukemia, severe anemia, vasculitis, or scurvy. We obviously investigated this patient further, and we found a total leukocyte count to be 54,000 per millimeter cube. And the peripheral blood smear showed leukocytosis, myelocytes, and metamyelocytes. So this patient was referred to an internist, and they came up with the diagnosis of chronic myelogenous leukemia. And the hemato-oncologist started him on dasatinib. And the patient came to us a couple of years later, perfectly healthy. And you can see how those hemorrhages have totally disappeared. And of course, he has no visual complaints, but this is a patient we could help diagnose at an early stage of CML. This 43-year-old gentleman was supposed to undergo a corneal transplant in the right eye, and he had no other complaints in the left eye. The corneal surgeon had sent him initially for an ultrasound, and the ultrasound threw up some findings, which was 2 mass lesions, which had been measured to be about 0.5 millimeter, involving the retina in the right eye. So this is just an external photograph of the patient, and you can see the right eye has a total corneal opacity and a little bit of an esotropia, and the left eye the anterior segment was normal. Never miss the opportunity to look at the retina of the fellow eye. And when we did that, we saw that the left eye retina also had this translucent grayish white mass abutting the optic nerve. Just to zoom in, you can see that it's almost mingling with the optic nerve with the retinal blood vessels overlying it. At this moment, it's always useful to take a step back. And when we look at the patient more comprehensively, you can see that those lesions on the face were nothing but adenoma sebaceum, which are facial angiomas. And on asking the patient to lift up his shirt and examining his back, we can see those hypopigmented ash leaf macules, whitish elevated patch on the back of the patient. So a true complete diagnosis would be tuberous sclerosis with bilateral retinal astrocytomas and a right eye corneal opacity. He was referred to an internist who advised him MRI and further investigations. However, the patient was lost to our follow-up. I do hope he's following up somewhere. But it's important in his case that we diagnose this condition because tuberous sclerosis has involvement of multi-organ systems being a phakomatosis. And you can see that these patients have almost a 40% chance of epilepsy and CNS tumors, as well as kidney renal cell carcinoma as well. This was a 55-year-old gentleman who presented with drop in the left eye vision since 2 days and complained of not being able to see the lower half. Now, his systemic history was significant in that he had been previously diagnosed to have chronic lymphocytic leukemia, stage 0. We'll come to the staging a little later, but CLL stage 0 essentially has, there's no treatment required at this stage as per the current guideline-based treatments. Now, this was the fundus examination showing an area of retinal opacification in the superior retinal hemifield corresponding to his inferior scotoma. And you can see the opacification along with a lot of hemorrhages along the in the peripapillary area. So this was like an arterial occlusion. Now, on the basis of this, we immediately did a paracentesis and started anti-glaucoma medication. And over a period of time, his vision did improve. But what was more important was that when we spoke to his hemato-oncologist, they decided to treat this patient because of this arterial occlusion, and he was started on rituximab and bendamustine. So this was a patient who would otherwise not have qualified for treatment of CLL, but did undergo treatment of CLL because of his ophthalmic manifestations. We've all seen, retina specialists at least have seen patients like this. This was a 28-year-old woman who presented with poor vision in the left eye since 2 days, and pardon me for the poor quality of the fundus photograph, but you can see that there's a large red retinal tumorous lesion in the mid-periphery with engorged feeder vessels, and the OCT showing a large amount of subretinal fluid and cystoid macular edema. Now, this is nothing but a retinal capillary hemangioma, and that has a strong association with von Hippel-Lindau syndrome, another of the phacomatoses, which can also have development of pheochromocytoma or renal cell carcinomas, which could be devastating and fatal. So what was interesting in this patient was we were not very sure whether a single retinal or solitary retinal capillary hemangioma really confers a risk of VHL. And on literature review, it was wonderful to find an article that answered this very question, published by Dr. Arun Singh and the Shields group, which talked about the increasing, the reducing risk of VHL as the patient's age increases. So this patient, however, did warrant further investigation, which all came out to be negative, but we did cryo to the lesion and the subretinal fluid totally resolved, and the patient actually improved to 6/6, 6 months post-cryo. So treatment of the ophthalmic condition is of course important, and that's what we do, but it was very important to note in this young lady of a childbearing age, what was her risk of having VHL and what was the subsequent risk for her future progeny. A 54-year-old gentleman came to us about 6 years ago with blurring of vision in the right eye since 2 months, and his left eye had poor vision since childhood. Now, he had been seen elsewhere twice and he had been advised cataract surgery, and he actually came into our hospital to undergo cataract surgery. But our cataract surgeon felt that the cataract was just not good, was not enough to warrant his poor vision. He had a refractive error of +3 in the right eye, which only improved his vision to 6/18 and 8. And the left eye was definitely a high hyperope with amblyopia with a refractive error of 9.75. Now, like I said, the slit lamp only showed an early nuclear sclerosis, and the fundus examination was totally normal. So he was referred to the retina clinic with this fairly common statement that the vision is not correlating with the cataract. On a hunch, we did a perimetry. Now, the perimetry was only possible in the right eye. The vision in the left eye was too poor. And you can see a hemianopia on the right side. So this could be either a part of a bitemporal hemianopia or a right homonymous hemianopia. But all said and done, both of these conditions would warrant neuroimaging. And that's what we sent the patient for. And we could detect a large cellular mass, more than a centimeter in diameter, this was nothing but a pituitary macroadenoma producing compressive optic neuropathy. And he underwent a transsphenoidal resection rather than cataract surgery. And when he presented to us 6 months later, there was clearing of the visual field. But of course, the cataract was the same, and he didn't require cataract surgery for many, many years later. So how does one diagnose conditions that warrant further investigation or referral? Now, I think a high index of suspicion, as we all say, is very important. The reported history, especially the duration of complaints and the onset of complaints, a very rapid onset of vision loss does not really correlate with conditions like cataract or even a refractive error. And therefore, one should correlate the anterior segment findings and the posterior segment findings with the history. There's a term called diagnostic momentum. When a 65-year-old person, a patient comes into our clinic with drop in vision, we automatically think of cataract. And if the patient is phakic, most of the times we just come to that conclusion without performing a complete examination. So as a rule, we examine all new patients, the retina of all new patients by dilation. And follow-up patients should be examined at least once in a year with dilated fundus examination. So this protocol could vary from center to center, but it's an essential part of an eye examination. And I think the days are gone where anterior segment examination versus referral for a posterior segment examination used to be the norm. How does one treat? Now, most of the conditions that I discussed are actually treated by other specialties, but the ophthalmologist is often required for regular and possibly lifelong follow-up. In many conditions which I have discussed, the ophthalmologist can help monitor disease activity and progression. For example, perimetry, which is a much cheaper and much simpler test, could obviate the need for neuroimaging in patients with pituitary adenomas, and these have been studied and published. So an ophthalmologist is always going to be involved in the lifelong follow-up of these patients. I do believe that these patients should be referred at the drop of a hat to either another ophthalmic super specialist, or in cases when one is confident of a diagnosis, to a different discipline, whether it is neurology, neurosurgery, endocrinology, hemato-oncology. So there are bridges one needs to build with other specialists and other departments. I conclude by saying that there is really a need for us to widen our horizons. Now, this is a typical fundus diagram that is drawn by residents and fellows, focusing only on the disc and the macula, probably because this is the view that one gets through a 90D slit lamp biomicroscopic examination. And one really has to stress to them that what you're seeing is very, very limited. You need to really look at the retina in whole, but also, just to use a cliche, look at the patient as a whole, because the retinal examination is nothing but a window to the rest of the general health of the patient. So with that, I would conclude and say that we really have an important role as ophthalmologists and retina specialists to take part in the diagnosis and treatment of life-threatening disorders and make a difference in patients' care. Thank you so much.